The following program presents principles designed to promote good health and is not intended to take the place of personalized professional care. The opinions and ideas expressed are those of the speaker. Viewers are encouraged to draw their own conclusions about the information presented.
Hello and welcome to Health for a Lifetime. We're glad that you're with us. And Dr. Alan Handysides, we're glad that you're with us as well today.
Thank you. Thank you very
Now,
much.
your role is with the General Conference of Seventh-day Adventists. You're a physician that works for them, and it's no longer Health and Temperance, it's Health Ministries Department.
That's correct.
Correct?
Yeah.
And you have kind of a global perspective, and you look at the major killers around the globe, not just maybe in one country, but you're kind of in charge of different departments that look around the world.
That's right.
Now, here in America, it's my understanding that one of the major killers is heart disease.
You're right. It sure is.
But what about in terms of a global health issue? Is it an important issue globally?
It's probably not as much of a global issue in some of the developing countries, but you must remember countries like those in Europe and certain parts of the Far East are becoming very sophisticated societies, and heart disease is becoming an increasing problem in those societies.
Like Singapore and...
Singapore and Korea, for instance, is becoming much more sophisticated.
Big cities in China?
I don't think the Chinese are probably quite into the high fat intake that we are as yet, but they're moving that direction.
So why is heart health such an important issue? You look at the whole body, you've got your liver, you've got your knees, you've got your nose, you've got your heart. Why is the heart so important? I mean, that may be begging the question, but
of course,
why?
you're leading me on.
Why is that is that so important to you?
If we cut off your nose, you wouldn't look so good, but you'd still carry on.
That's right.
If we cut out your heart, you stop dead.
Right.
Now, the thing is that there are 500,000 deaths a year in the United States, secondary to heart disease. It's estimated that there will be about 70% of the male population will have heart disease.
70%. That will
70%.
be one of the causes that leads to their demise.
That's right. And women, it's a little less, maybe down to 55% of women will have heart disease. That doesn't mean that they don't necessarily they don't have heart disease, but they don't have symptoms of heart disease.
Okay.
And they don't to show that they have heart disease.
Now, when you talk about heart disease, when you're talking about heart disease, I think about different things. I think about, an enlarged heart, or some people call that congestive heart failure. I think about a heart attack. I think about a problem with one of the valves. What do you mean when you say that?
Well, when I say that, I'm really talking about arteriosclerotic heart disease. So we're talking a vascular problem.
Okay.
Feeding the heart. Now this, separates it from the children born with congenital heart disease. It separates off those with acquired heart disease such as rheumatic fever. And I'm not really talking about people who have an infected heart problem, like some of the myocardiopathies, nor things like subacute bacterial endocarditis, which proportionate to the rest of heart disease are a very small proportion.
So infections in the heart, that kind of stuff.
Yeah, they occur, and but they're somewhat exotic,
Now, your training is with women's health issues and also with pediatrics. But speaking of pediatrics or children, is it a big problem with children heart disease?
Well, that's heart disease. The congenital heart disease is a big problem. I remember when I worked at the Hospital for Sick Children. Any one day, we could count maybe 65 children in the hospital with a congenital abnormality. They would do perhaps every day 25, 30 cardiac catheterizations to diagnose what the problem was. But very seldom did we see arteriosclerotic heart disease, although our pathologists told us that when they did autopsies on children, they could see in the children arteriosclerotic changes in children as young as a year of age. Already beginning to see change there.
And what was that coming from, did they think? And what did they find in there?
We felt that that was probably related to the fat content, the high fat content in even infant formulas, the diets that children were receiving that weren't being breastfed.
Well, let's talk about that fat intake. What's that? What's the relationship between fat and heart disease?
Can I beg to just go back a little bit and
sure.
to talk about heart disease? Perhaps the underlying lesion in heart disease is what we call plaque. Underneath the intima, or the lining of the blood vessel, here's the blood vessel, underneath the lining, the little tiny one-cell skin of the lining, there's an accumulation of material. Now, we've tended to think that that's just fat. Well, that's erroneous. It's not just fat. Probably there's a damage. First of all, an intimal damage takes place, damage to that lining. That may be because of oxidized low-density lipoproteins, a form of cholesterol. It may be because of bacteria. There's even an association between dental health and heart disease. So it may be bacteria similar to those that are around our teeth and gums in gingivitis. That's just whatever the trigger is, it sets up an inflammatory process. And that inflammatory process calls in tissue white blood cells, macrophages, platelets clot onto this damaged area, fibrin, which is a proteinaceous material, is released in there, and so we get a buildup of these various substances. It's not just pure fat sitting on the blood vessels.
So damage to that inner layer, and whatever that damage comes from, could be different factors you're saying, it causes these other blood clot type things to come to the area.
Well, and it's what it does is it gradually expands and closes down the space within the vessel. Now, if you take a half-inch pipe in plumbing and you compare it to a 1-inch pipe in plumbing, you'd say, well, I'm getting half the flow through the 1-inch pipe, the half-inch pipe, than I'd get through the 1-inch. That's not correct. The flow is not just halved when you go from 1-inch to half-inch. It's to a factor of about 16 for same pressure and things like that. So in other words, this narrowing of the blood vessels, particularly in our heart vessels, is very, very significant and very important.
So it's sort of like a garden hose when you squeeze it. It really has pressure.
Really has a lot of change on those vessels.
Well, what about the fat thing? Let's come back to that. How does fat relate to heart disease then?
Well, the fats that are carried around in our body, fats are very important to us. I mean, we can't live without fats.
More important to some people than others.
Definitely. But the balance of the fats have a very important role to play in heart health. Remember, I said that one of the triggers is the oxidized low-density lipoproteins, the LDL. Now, if you have an elevated level of LDL, then you're going to find that there's more chance of them being oxidized. And of course, that's where antioxidants come in and protect against that. And they will then be deposited part of that motley crew of substances in that plaque.
And that's the thing that messes up the intima.
That's what's going to mess up the intima.
Okay.
High-density lipoproteins, on the other hand, they are important for removing oxidized low-density lipoproteins from the clot. So if we have higher levels of high-density lipoprotein, we get a better balance. And of course, the total cholesterol has a bearing on all of these factors. Now, where do these come from? They come from the fats that we eat. So if we, as the average American, is eating 40% of our calories from fats, we're taking far too much for our body's needs, far too much for our body to be able to cope with. And so we throw these fats in our blood, we throw them into imbalance. Now, the saturated fats, which come from animal sources, are by far and away the most dangerous of the fats. And we would like to see saturated fats reduced, brought right down low. There are some other fats that are good for us, although nothing is absolutely black and white in this area, but they are better for us, and we should have proportionately more. And those are the unsaturated fats, and particularly the monounsaturated fatty acids, which we call MUFAs.
So what would be some examples of the MUFAs?
Well, the MUFAs, if you read in the common literature, they'll talk about fish oils. They'll be talking about fish oils as being a good source of MUFAs.
Flaxseed, though.
Aha. But you see, when you take something that may be polluted, you know, look at the mercury levels in the sea or in the the dioxins and so forth, then you're running the problems of these other contaminants. Whereas if you take the MUFAs, say, in flax seed, then you're going to be able to take a higher level of monounsaturated fatty acids without the collateral problems that come along with some of those other
But if you just say no fat, you may cut out the omega-3s, and that could be damage to what?
Oh, that's right. Nobody today is saying no fat. You know, I don't think anybody who is current is saying no fat. We all know. We don't want the cholesterols to go to nothing, because cholesterols are important for brain function, neural function, and so forth. In fact, there's been some studies that are done on excessively low cholesterol levels being associated with depression, psychiatric disorders, even increased suicide rates have been correlated with very low cholesterol levels. So what we try to aim for is the healthiest levels, and they've just revised the cholesterol levels.
What are they now? What should they be?
Okay, they've left the total cholesterol level 200 milligrams per 100 milliliters. That's stayed the same, although there has been some thought that maybe they should lower that, but they've left that the same. But they have raised the level of high-density lipoproteins. They now say instead of 35 being the low, they'd like to see 40. In other words, you should be above 40 with your high-density lipoproteins. And then for your low-density lipoproteins, they would like those a little lower. And so they now look at a level, once you start getting above 65 to 90, they say that's not a good level.
So they're adjusting now these levels at a national level or international level.
That's right.
And they're saying
let's be more stringent on our cholesterol.
When should we start checking our cholesterol, and how often? I mean, you're a pediatrician. Should children have cholesterol checks?
I think we should start at maybe about age 20. The reason I would recommend that is that it's a national recommendation, but also because you will pick up those people who have familial inherited problems with fat regulation, and those people need to be very, very careful about their diet and their lifestyle. They may even need to go on cholesterol-lowering medications because they have an abnormal high
even if it's
enzyme problem.
Even if it's familial. In other words, like let's say you had someone that's not eating high-fat foods, not eating high cholesterol foods, but they still have a high cholesterol.
They're in real danger. Yes, so they have a metabolic disorder. If we were to compare them to the diabetics, we'd say they're like the type 1 diabetics. They're genetically in trouble. Then there's the vast majority of us run into cholesterol troubles because we are like the type 2 diabetics. We're out of whack with our lifestyle. But that group, they will be benefiting by having their cholesterols measured when they're early. And then maybe every 5 years thereafter we should have this profile to keep an idea as to where we're going with our cholesterols and fats.
So we need to know our numbers.
We need to know our numbers, arithmetic, basic stuff.
Know where they are. Okay, other important aspects of heart health. We talked about cholesterol. We talked about, the vascular.
We can't leave it without talking about smoking.
Smoking. Okay.
No way that we can leave without talking about smoking. Smoking is one of those factors that damages the intima. So it is an initiating factor in setting up the process.
So how does that work? You smoke, it goes into
the nicotine goes in there, causes vasoconstriction, maybe hypoxic damage, we don't know, maybe direct chemical damage from some of the contents of the smoking. Okay. And here you've got the beginning, the seed is sown for arteriosclerotic heart disease.
Someone told me once that in that layer, and I'm just checking with you to see if that's true, there's a substance that's released right in that layer, inner layer, that's sort of like nitroglycerin. It's sort of like that. It can help it relax, but when you smoke, that disrupts that. Am I correct on that?
That's right. It interferes with the vasoactive components in the vessel. It causes spasm, and in and of itself narrows the vessel. I had a colleague. He was a physician. Should have known far better. He got chest pain. He sat down and he said, I think I'll have a cigarette. I don't feel good. Took the cigarette, and he was found dead in the office.
Is that right?
But the cigarette probably was the straw that broke the camel's back in his particular situation.
What would be the most dangerous? And I hate to put you on record as saying what this is, and maybe you don't want to be on record. But let's say you had to choose between that very high-fat diet and cigarette smoking. Which is the most dangerous of those two?
Oh, that's like saying, which would you rather be run over by a Mack truck or be run over by, a train or something? They're both bad. I mean, they're very, very bad. Now, one thing, another factor is exercise. Mm-hmm. And in our lifestyle, we love to talk about foods, mm-hmm. but exercise we don't like to have. We talk about it a little bit. We don't like to do it. To get that sweat there and to work it up and 20 minutes a day of come out in a light sweat. Mm-hmm. You sort of feel hot for the next hour. We don't like that kind of feeling.
We don't want to be uncomfortable.
And yet, statistics show that a fit smoker, as far as health risk is concerned, is no worse off than an unfit non-smoker.
A fit smoker is no worse off than an unfit non-smoker. You've heard it right here. That's kind of bad news maybe for some of us. We're talking to Dr. Alan Handysides. Join us when we come back to talk about heart health.
Have you found yourself wishing that you could shed a few pounds? Have you been on a diet for most of your life, but not found anything that will really keep the weight off? If you've answered yes to any of these questions, then we have a solution for you that works. Dr. Hans Diehl and Dr. Eileen Luddington have written a marvelous booklet called Reversing Obesity Naturally, and we'd like to send it to you free of charge. Here's a medically sound approach successfully used by thousands who were able to eat more and lose weight permanently without feeling guilty or hungry through lifestyle medicine. Dr. Diehl and Dr. Luddington have been featured on 3ABN, and in this booklet, they present a sensible approach to eating, nutrition, and lifestyle changes that can help you prevent heart disease, diabetes, and even cancer. Call or write today for your free copy of Reversing Obesity Naturally, and you could be on your way to a healthier, happier you. It's absolutely free of charge, so call or write today.
Welcome back. We've been talking about your heart and health, and we've been talking about the fact that there are a lot of things we can do to avoid heart disease, one of America's #1 killers and a global concern as well. When we left, we were talking about exercise, and you were telling me that a smoker who's fit is no better off, really, or than the person that's not fit who doesn't smoke. They're about the same, and you were telling me it's a 1 pack a day type smoker.
That's on a 1 pack a day, yes. A person who smokes 1 pack a day but is an athlete and is fit is no worse off than the non-smoker who's a couch potato.
So we do need to be exercising. That's what you're telling us.
That's what we're saying.
That.
Yeah, that's what we're saying.
And when we say exercise, does this have to be aerobic exercise? Does it have to be, or does anything help?
Well, I suppose anything's better than nothing, but there are some things that are better than others. Walking, for most people, is probably the easiest and simplest way of achieving heart health. Now, you need to walk probably briskly for about 20 minutes, but people mustn't go out. Anybody listening to this program mustn't go out and walk briskly for 20 minutes. They need to know where they are at
before they try that.
Before they try that. But they need to be able to, in graduated exercise, get to the point that they can walk 20 minutes briskly and breaking a light sweat, and that would give definite and proven benefits.
Now, if you're out there walking briskly or whatever, and you've been cleared by your doctor or lightly, and what are the symptoms of heart disease, maybe not just for walking, but other symptoms as well? What are warning signals that you better go in and get checked out by your physician? Interestingly,
they're different between males and females.
Okay.
We've traditionally taught both physicians and the public that the crushing pain in the chest, the elephant foot just on there, that tightness that comes on with exercise or with exertion, anger, stress, that could be a sign of cardiac disease. And in the male, he may develop angina, and the angina is symptoms of the pain that may be associated with a heart attack, but it disappears when the activity
goes away.
Is stopped.
All right.
So and it repeats, the pattern repeats itself. That's angina. Angina doesn't last for just a couple of seconds. Angina isn't something that you can induce by pressing on your chest. A lot of people have tenderness on the chest. They think that that's heart pain. That's not heart pain.
Connective tissue or something.
That's connective tissue, muscle, joint, something like that. The difference with women is that women will often have associated nausea or fatigue, and the pain often goes up into the neck and into the jaw.
I see.
So they may be getting a jaw pain or a neck pain, referred pain, and not recognize it. And for many years, doctors misdiagnosed women because they were looking for something other than heart disease. We also thought that women were protected against heart disease, but now we know within 7 years of the menopause, women are just as likely as men to have cardiovascular problems.
So we have to keep aware of the symptoms are different for men and women. What is the youngest person you've seen that's had a heart attack?
I saw a 14-year-old boy die of a classical myocardial infarction at the Hospital for Sick Children. Now, he was a diabetic, which brings us to another factor, but he was a diabetic, and he died. And at autopsy, his vessels looked like those of a 75-year-old man.
The diabetes maybe just accelerated the problems with his vessels.
Well, the diabetes definitely accelerates the problems. The diabetes causes atherosclerosis, it causes small vessel disease, and it interferes with fat metabolism, and of course insulin resistance is very present in a lot of diabetics.
So, you know, the youngest I ever saw when I was working in an emergency department, we'd see a lot of people come in and we'd have 5 or 6 heart attacks at a time in the morning, you know.
That's right.
In the hospital there, was a 17-year-old that had, you know, none of this, not a diabetic or anything. So the only reason I asked the question was to see if I was right, which I was going to say, look, this is something we need to think about a lot younger.
But those are the exceptions.
Sure.
But we do need to think about it. In fact, what we need to do is we need, as a people here in North America, to think about our lifestyle. We need to say, when are we going to take care of ourselves? Stop being couch potatoes. Reduce that fat content in it. Watch out for the smoking. When are we going to sort of protect our young people against these evils that are health hazards?
So those are really things that you're clicking out there that we can do to prevent heart disease.
That's right. Definitely.
Get them out there working, not being couch potatoes. Make sure, there's an exercise program. Have them eating the right kind of food so they don't like that fat taste and just subsist on that. And what else to prevent?
Well, the other thing, of course, is the positive benefits that come from all these antioxidants. If you're going to talk about foods that are protective, antioxidant foods, you have to think about the rainbow. We just had a thunderstorm that's gone on outside, which I hope that they haven't heard on the program here. But the colors of the rainbow, if you look for the colors of the rainbow in your diet, you know you're getting the right foods, those beautiful reds and those lovely yellow, greens.
And this isn't red Jell-O, green
no,
Jell-O.
This isn't artificial flavoring. This is the red tomatoes. This is those red berries, the deep plums.
All right.
The lovely, the fruits and the vegetables that are rich like that. And when we take these multiple colors in our diet, and that's an easy way. Anybody, you don't have to be a dietitian to put color in your diet. You know, those nice sweet potatoes with the orange hues.
All those things are really healthy for your heart.
Very healthy. Good antioxidants. Remember I said the oxidized low-density lipoprotein.
Okay.
The antioxidants are going to protect it. It's a wonderful net. This health business makes me just over and over again say, what a wonderful creator. You know, when he created us,
he gave us the right kind of food to
He gave us the right kind of food. He gave us the right system. You know, he created the metabolism in such a way that he could truly say when he created Adam and Eve, they're not only good.
Very good.
Very good, yeah.
Now, what if you've had a heart attack? I mean, we're talking about preventing and avoiding. If you've had a heart attack, is there any hope that you can give someone that's had a heart attack?
Of course. People live for years after a heart attack. Of course, that's if they take take heed of the warning. They say, my goodness, I've had this heart attack, I better mend my ways. And they go through the same things that we've talked about, although they now need to do it under medical supervision. The exercise needs to be very graduated. But in this area, very interesting study showed that men who'd had heart attacks who did not have social support, they didn't have a wife and a family, they were lonely people, those people died at 40 to 50% higher rates than the people who had the social support. Now there's something that we can do to help people who've had a heart attack. We can go and visit them. We can show them that we do care. And by the spirit of community, the spirit of social support, we can impact other people's lives.
So there's a role for a church group, there's a role for a civic group, there's a role for, you know, getting people involved, and this can really save their life.
This can save their life. Just the fact that they belong, the fact of connectedness, is very important.
Any other advances you'd like to share in the last 2 minutes we have?
Okay, well, you know, people are very interested in advances. Nowadays they're talking about threading tiny little probes into the cardiac vessels and maybe
putting a stent
that's
in,
right. They put a stent in there, or they blow up a balloon and they crush the plaque down, or they're even talking about lasers to vaporize the plaque, and what do they call these, you know, microwaves? They're experimenting with all these kind of things. And it sounds very wonderful, and I think it's very exciting as long as it's your heart that's being catheterized, not mine. You know? And I mean, I feel great if I'm a interventional radiologist. But really, the thing is, wouldn't it be better never to need all these wonderful advances?
So the greatest advance would be to not have to have the greatest advance.
That's the greatest advance, yeah. And I think we could do that. With this program that you have here, I congratulate you on this program of constantly repeating and educating the public as to ways and means that they can impact their own lives to the glory of God and to the enjoyment of life.
So it's true or false? It can be reversed. You can have a plaque that then diminishes over time.
Yes, you can reverse it. Not in everybody, not everyone. I would think that probably you can also dilate the blood vessels. You can restore some of the elasticity to the vessels. But overall, you can definitely improve the situation. And in some cases, the plaque has been demonstrated to be removed.
That's good news. Real good news. We've been talking with Dr. Alan Handysides. He's given us not only a picture of heart disease in America, but globally. And he shared some good news. There are some things that we can do to prevent, reverse, or better yet, avoid heart disease. We can exercise, we can eat right, we can trust in God, have a social support system. We hope this has been helpful.